Welcome everyone on board. We had started to discuss some of the topics which are important with reference to ICU. Yesterday we discussed about muscle weakness, and then we just gone through all the possible causes of like muscle disease, neuromuscular diseases. So today we will just have a look on this topic of poisoning. So um, actually, this because poisoning they can ask you with reference to specific poisoning, okay, and actually poisoning in virtual sense, even the drug overdosage which we can do iatrogenically by mistake, by like suicidal. There are so many different scenarios in which they can ask you. There are some journal principles if you are suspecting a poisoning. So, Safiullah, can you just tell that what will be the journal features if we are suspecting any poisoning? Like, what can be the various presentations in which you have to, in the differential diagnosis, you should consider a poisoning?
Sir, general features can affect the different systems, like we can say in CNS, there could be confusion and then irritability, and of course, drowsiness. And also, if we say that in CVS, it could be hypotension, arrhythmias, and see respiration. There could be tachypnea, or decrease respiration, bradypnea, we can call it. And then in GI, we could say that if the patient is having vomiting, nausea, vomiting, diarrhea, and things like that, and respiration bronchospasm could be also there. If the features are involving more systems, and the history is acute, very short duration, so we could suspect, and then it can affect the other system as well, like eyes, like kidneys, like skin. So depends upon which poisons atrogenically has been given, or the patient has taken.
Okay, so actually you can improve your answer in a way that again the same airway breathing circulation will come to your help. So anything
Yeah.
related to airway, anything related to breathing, anything relating to circulation, and then generalize features. Okay. So loss of consciousness. Whenever there is loss of consciousness, one of the differential diagnosis, in addition to endocrine causes or cardiac causes or neurological causes, one of the causes will be poisoning. Okay. That maybe patient has taken something which has caused poisoning. Poisoning may be like suicidal or homicidal, okay, or accidental. It can be in all three ways. Somebody has poisoned, somebody has so actually in poisoning, topic is very broad. Okay, so in differential diagnosis of so many things, you can bring poisoning. Even in toxins, actually it's poisoning. What is we say in the five T's and five H's. Okay, so even it is part of five H's and five T's. So it you can just think in that ground. Okay. So any hemodynamic instability can occur, any respiratory problem can occur, and then one of the feature of if it's in oral form, one of the feature will be nausea or vomiting. Okay, because this is, you can say, a natural protective mechanism of the nature of Allah, that any toxin if enters in the body, the chemoreceptor trigger zone, which is outside of blood-brain barrier, it will try to protect, and it will immediately sense, and it will immediately try to initiate this process of vomiting. Just a second, please. Okay, so this is the chemoreceptor trigger zone will initiate vomiting. So this is a natural response of the body. Okay, so uh, if it is not there, then we can initiate vomiting as well. This will be initiating of vomiting, and then we can have a stomach wash. Okay, so this will be one mechanism which you will be seeing. Then what else? What else will be there in the management?
Sir, other than ABC and decontamination and exposure, exposing the patient, we would continue. If depends upon the history and the patient arrival time. If it is within an hour or two, then gastric
Yes.
lavage or activated charcoal and most of the poisoning is used.
Okay.
But in
So
some poisoning is
activated charcoal, what is the mechanism? It will just engulf and it will prevent the absorption. Am I right?
yes, sir.
Is it like this?
Uh, so, so, uh,
Yes.
yes, please speak. Someone is.
Yes, please
Sir,
speak.
actually, it's decreases the absorption of poisons. It's give a surface, the surface area on which it has to be absorbed, like on the mucosal surface. It spreads, so there is decreased absorption of the poisoning. I think through this mechanism,
Mhm.
the poison toxicity decreases.
Like it will be with reference to absorption. Okay. So this will
Yes,
be
sir.
one part. And then airway breathing circulation, you might need to secure the airway, ventilate
Yes,
the
sir.
patient, take the
Sir.
IV line, start fluid management, okay, and treat anything
Antidote.
anti. Yes, so antidote. Can you just think about maximum antidotes which we can have? Just think.
Uh, yes, sir. Sir, like in paracetamol, we give N-acetylcysteine, and opioid, we give naloxone, and
Okay,
benzodiazepine, we give flumazenil,
okay.
and carbon monoxide, we give oxygen, and
Oxygen or hyperbaric
hyperbaric oxygen. In cyanide poisoning, we give cyanocobalamin,
or
and
methylene blue.
methylene blue. Yes, sir. In warfarin, we give FFP, in heparin, we give protamine. In snake poisoning, we give anti-snake venom.
Anti anti-venom.
Uh,
Anti-venoms
sir,
and
anti-snake venom and antihistamine and epinephrine if needed. Uh, Other what could be other organophosphate poisoning? We give pralidoxime and atropine
pralidoxime or
and
atropine.
atropine, sir.
Okay.
And alcohol we give thiamine, I think, sir. Injection. It is
What
given.
about magnesium versus calcium and calcium
Uh,
versus magnesium? Okay.
Sir, yes, sir. If magnesium toxicity, then we give calcium gluconate injection.
And there
And
is
if
there is for digoxin toxicity. Also, there is
yes,
a
sir.
what's
Sir.
that? I don't remember the name. What is that for digoxin toxicity?
And for digoxin, I think some anti-ditch fragments. I'm also forgetting this, but maybe I'm back of my mind, not coming into this, not remembering now. And one other thing, sir. Mm, digoxin we have discussed, warfarin, some else I'm forgetting now.
Okay. So journal features. What about dialysis?
Yes, sir. Yes, sir. You were asking about calcium, sir. For calcium, we give bisphosphonates and hydration. If the calcium is toxicity is there, like with parathermone, adenoma, and hypercalcemia, hyperparathyroidism, or
For digoxin,
hypercalcemia.
we give digoxin immune fab.
Yes, digoxin and immune fab. Yes, thank you. Thank you.
Sir. Sir, what were you asking about? Something else?
No, no. The dialysis will be also part of
Yes.
management.
Yes,
Okay.
sir. Dialysis is also part if the patient is going into renal shutdown, and also we like for paracetamol poisoning criteria. If the King College criteria is there, then liver transplant thing like that can be also done. That is
Mm,
not good, but it's part of treatment. If
okay. Okay. So, now we are just trying to be a little more specific about it. So let's see. And this is actually this is a very old document, but it's very effective. So few points that they have written that for activated charcoal, these are the drugs in which you need to give number of times. Carbamazepine, Dapsone, digoxin, paraquat, phenobarbital, quinine, and theophylline, this fungus. So, okay. So, what about some antidepressants?
sir, antidepressant like tricyclic antidepressant, it causes cardiotoxicity, convulsions, and coma. So we have to treat those. I think, like for convulsions, we have to give anti-epileptic. Uh, for cardiotoxicity, we have to treat it by anti-arrhythmias. Uh,
Yes,
sir, and
like the
Sodium bicarbonate we give for
for
tricyclic
yes,
overdose.
yes. For aspirin, if it causes acidosis, then also it would be given soda bicarb. He is right, sir.
yes. So you see, for tricyclic antidepressant, toxicity, anticholinergic effects are there. Okay, because
Yes,
actually
sir.
remember one thing that all antidepressants increase the catecholamines in some way or other.
Yes,
Okay. So
yes,
and TCAs are more they are generalized increasing, and they also have anticholinergic effects. So they will have effects like central anticholinergic syndromes. So
yes, sir.
and it also prolongs QT. And prolonged QT will lead to even the this one
QT
uh,
prolongation.
and ventricular fibrillation. Okay, so it's also a sort of precursor for and this one. So and so one so like we are discussing the generalized treatment. So antiarrhythmics are also one of the things which you need to have. Okay,
Yes,
and in serotonin syndrome, what we do? Uh,
sir. And serotonin syndrome.
because it's like
Uh,
a hyperthermic, because it's also a differential diagnosis of hyperthermia problems and
yes,
increased metabolic problems. Okay.
yes, sir. It's actually, sir, a life-threatening condition in which there is which occur because of drug interaction, uh, and this central effects are there, and of course there are autonomic dysfunctions, and central it could be confusions, agitation, and seizures, and autonomic there could be increased temperature, sweating, hypertension, and some neuromuscular effects could be also there, like tremors and hyperreflexia. I think the treatment for serotonin syndrome is to stop and avoid the drugs yes, sorry.
No, no, this is just someone has in the mic.
Okay,
Anyways, yes, please
okay, sir.
continue.
Sir, cyproheptadine, I think I have read somewhere. Cyproheptadine is
Anti,
used,
yes, and
sir,
this is antagonist.
antagonist, sir.
So,
Uh, we should remember that the drugs which causing AIDS should be avoided, sir.
oh, sorry,
Like
what's that?
sir, like
Tachycardia,
pethidine. Yes,
pethine, ketamine, ephedrine.
ephedrine, sir.
So,
The pethidine, tramol with some tricyclic or MAO inhibitors, like such sort of drugs should be avoided because they can cause.
okay. So, similarly, if we consider this salicylate, So in salicylate, it can cause actually GI problems
Yes,
as
sir.
well as acidosis. So it can cause even GI bleeding. Okay. And
Yes.
this is that the toxic effect complex include the direct stimulation of respiratory centers, inhibition of citric acid cycle, and coupling of oxidative phosphorylation, increased metabolism of fatty acids, nausea, vomiting, tinnitus, lethargy, so dehydration, restlessness, sweating, vasodilatation, hyperventilation. So not only the uh, this one activated charcoal, okay, and what else? ABGs, so treatment of acidosis. So acidosis treatment will be there. Uh,
Yes.
can it be this hemodialysis? So it is one of the medication which can be treated with hemodialysis. So that's why
Yes.
we, yeah, 2 days ago when we were discussing, so CRRT, you should be very carefully read what medications can be treated with dialysis. Okay.
Yes.
So this is something which you should not forget. And any hypermetabolic or features in any disease, anything. So you consider rhabdomyolysis and then AKI. So these things are also correlated. Okay. And as mentioned here, any acids are there. So if you want to treat, you can have urinary if you achieve the pH, so it will draw the acids out. Okay. So urinary pH of 7.5 to 8.5, repeating treatment if necessary to achieve a falling plasma salicylate levels. So these are the thing. Alkaline, you see, forced alkaline diuresis should not be used as it carries a significant risk of pulmonary edema. In severe poisoning with evidence of cardiac or renal failure. So hemodialysis treatment of choice. What about alcohol?
Sir, alcohol depends upon that what alcohol has been, like ethanol, methanol has been taken, uh, and it could be accidentally, like by the children, or it could be intentionally. It is taken. Its effects are on CNS, in earlier
Alcohol
form, it
children?
could.
Alcohol children?
Yes,
From where children came?
yes, sir.
So
It can present with confusion, drowsiness, stupor, and then it can affect the hemodynamics, like hypotension, bradycardia, and vomiting. And then it can also present with some abnormal gait or ataxia and abnormal speech, and abdominal pain and things like that. It would the presentation it can involve multiple systems, sir.
and also hypoglycemia. Okay. Hypoglycemia should be treated as quickly as possible with oral glucose. So hemodialysis may also be required if the blood concentration is more than 5 gram per liter, if the pH is less than 7, if the patient condition deteriorates in spite of. Okay, so with reference to paracetamol, we have discussed a number of times that the metabolite of paracetamol, which is NAPKI, is usually treated by the liver by conjugation. But if it overloads the burden of this thing, then it will damage. So the management will be N-acetylcysteine, and they can
Yes.
ask you about this normogram. Okay. So the basic theory of understanding is that if it is falling levels with time, okay. So if it is falling in between, then you have to give N-acetylcysteine. What is the mechanism of N-acetylcysteine?
Sir, that I don't remember, sir.
Sir, I think
Glutathione.
it glutathione, yes.
Sir,
It
glutathione is depleted by NABQ, na?
So it
Like
is
cytochrome.
replenishing the restores the this glutathione. Okay.
Oh,
So in rest of the things will be generalized. So because liver failure can occur, So all the features of acute liver failure should be in your mind whenever they are asking paracetamol poisoning. So yes, these specific things will be there in your mind, but also think that acute liver failure features can be there, like all
Yeah.
the encephalopathy and coagulopathy, everything can occur. Okay, and then they can ask you about this King's College classification, and so you mm, ALT, creatinine, INR. This is for this one King's College criteria. So okay. So what about organophosphate poisoning?
Sir, in organophosphate poisoning, actually there is acetylcholinesterase enzymes, and those are depleted. The acetylcholinesterase inhibitors
So it is like
actually,
a lot of acetylcholine is there. So all the acetylcholine
yes,
cholinergic effects will be there. Okay.
yes. So cholinergic and muscarinic effects are also there, sir.
Yes. So
Nicotinic.
in it will causes fasciculations but weakness. Okay.
Yes,
And then hypersecretions will be there, bradycardia, a lot of
yes, sir.
secretions, vomiting, and
Salivation,
yes. So
nation, and
what will be the airway breathing circulation? Okay, and
sir,
then atropine infusion or
atropine.
atropine continuous infusion will be required, and then these pralidoxime reactivated phosphorylated acetylcholinesterase before deactivation occurs, and are clinically used to reverse neuromuscular blockade. Okay, so they can ask you about the dose and how the mechanism occurs. So rest of the thing, another thing which we forgot to mention, and conscious level and also fits. So in a number of poisonings, there will be
Yes,
use of anti-epileptics. You mentioned about anti-epileptics. So anti-epileptics or like specifically benzodiazepine to calm down the patient. Okay, carbon monoxide comes with like usually with the thermal injuries, burn. Okay, or not burn, only closed cavity. Sorry, closed in an area where there is a smoke, and so it in that case it may be without a burn. Otherwise, it may be as a part of trauma with the blast injuries. Okay. So whenever they are asking or discussing about more carbon monoxide poisoning, you have to mention that you have to see what is the like mechanism of this
okay.
occurrence. So if it is
Injury.
trauma, so you have to say about ATLS. If it is burn, you have to tell about the burn. And if it's specifically carbon monoxide, what will be the treatment?
Sir,
Oxygen therapy.
oxygen therapy, airway breathing and circulation.
Mhm.
And
الله خرخر.
room
What
air
with
take 4 hours with 100%
what is
oxygen it
the
takes.
what is the mechanism, Zishan, if you can also participate?
Yeah,
What will be the effect or hyperbaric oxygen?
Sir, basically carbon monoxide has more affinity for hemoglobin than oxygen. So basically, it's a competition with oxygen, and it has more affinity. So when hyperbaric is given, so it gives more oxygen to hemoglobin, and the
I'm
time
afraid
also reduces.
I'm afraid you are wrong. I'm afraid you are wrong. Anyone else?
sir, I think he's right. It increase oxygen delivery basically
How?
because
You
like
are missing something. What is the formula of oxygen content?
Sir, it
oxygen
is
content depends upon
1.34 into HB into partial pressure of oxygen.
No, 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 not partial pressure. SpO2 into hemoglobin
SPO.
SP.
Yes, sir.
plus
Plus zero
0.003
point.
into PO2.
Yes, sir.
So now tell me where it is occurring. It is acting on this side or this side?
Sir, on the
On the
it is occurring on the right side,
This
sir.
right side. Okay. So it has nothing to do with carbon monoxide. Remember, it has nothing to do with the affinity because this is hyperbaric. Okay. So it has nothing to do with this one. I hope you understand. This is the
Yes,
concept.
sir.
Usually, how much oxygen is required at the cellular level, at the mitochondrial level? What is posture
Five.
point?
Sir, posture point is that point in which after that anaerobic
So I
starts
think it
taking
is
place.
very low. I don't remember exactly the number. You should know the partial pressure. I think it is very low oxygen. Some 1 point something, if I'm not wrong. I forgot the number, but you should know. So actually, whenever we are giving, because carbon monoxide will be, it is removed in the blood by its own metabolism. So it will take its time and it will wash out. Whenever you are giving more oxygen, it is, yes, if you are giving 100% oxygen, it is trying to compete here. Okay. But if you are giving hyperbaric oxygen, it is acting here because it will be increasing the dissolved part. Okay. So I hope you understand.
Yes, sir.
So that is the
sir,
mechanism, Yes.
sir, do you mean like we have said that an oxygen contain 1.34 into hemoglobin and to SpO2 plus 0.003 and to PaO2. The
Yes.
dissolved
So PO2.
oxygen
So
PO2,
here it was
PaO2.
before 1 atmosphere. Now you are giving at 3 atmosphere. So it will increase this part. It is helping
Okay.
in oxygen content because this part is now is out of control. Okay. So you are trying to effect on this part. The same hyperbaric. What are the other uses of hyperbaric oxygen?
Sir, it could be also used in
Sir, I think
burns
Gas
in
grafts,
and hyper
free
yeah,
flaps.
free flip in high altitude injuries, I think.
You are talking about what? So this one I,
Like
I remember very bad infection,
Diving or drowning injuries.
drowning.
uh,
Hyperbaric, sir, for treatment of
Anyway,
drowned.
I think in subatmospheric, like deep sea and at very high altitude when there is a partial pressure of oxygen deficient, no?
yes. So
Uh,
the AI is helping us decompression sickness, and then
yes,
this bad wounds. Okay, diabetic
yes,
ulcers, radiation injuries. I don't know. Anyway, decompression sickness are. So these are the use of hyperbaric oxygen. Okay. So carbon. Okay, just one thing, because we will go one by one. What about beta blockers? If beta blockers are given in high dose, what will be the
sir.
treatment?
Sir, one is general treatment and the other one is specific, that is antidote, na?
Hmm.
So, as far as general treatment, again, we would say that airway breathing and circulation, and the specific antidote for it is glucagon.
Will
So
it
we have
respond
to
to
use.
atropine?
No, sir. I think it would respond to glucagon only.
There is some
Okay.
role of aminophylline, sir.
Aminophylline? I don't know. Like, yes, maybe because it is alternative mechanisms. Okay. So, because all the beta blocker has what sort of effects? So it has negative inotropic and
Sir,
negative chronotropic.
chronotropic.
Okay. So uh, they you have to think that, so for chronotropy you are giving this glucagon and everything. For inotropy you might need to give, like calcium is one of them, or you might need some inotropic effects. Okay. Okay. So let's have a look. Just a second, please. So somebody has you see one we did not mention about warfarin. We said FFPs, but also vitamin K. Okay,
Yes,
benzodiazepine, flumazenil, magnesium sulfate, calcium gluconate or calcium chloride, heparin, protamine, Tylenol. I'm not sure. This I think Tylenol is paracetamol and mucomus. They are writing this in N-acetylcysteine. Okay, so opioids. This naloxone. Then cholinergic medications, this atropine, pralidoxime, digoxin, digiband, this fab which we were discussing, acetaminophen and acetylcysteine, iron, that's ferroxamine. And what about copper? I think copper, ceruloplasmin, or something. Iron is desferoxamine. Okay. So alcohol withdrawal, Liberium. Uh, I'm not sure what is Liberium. Um, are they talking about thiamine, this Librium? I'm not sure. Beta blocker, glucagon, methotrexate. I think they have write some of the. Uh,
Sir, for copper, dipencilamine.
I'm sorry,
For copper, dipencilamine.
D-penicillamine. Okay. Okay. So yes, another toxicity, cocaine toxicity. So cocaine is a powerful vasoconstrictor. Okay. So it will cause severe hypertension and then it is causing coronary vasoconstriction. So it is causing like ischemia, severe ischemia, arrhythmias, heart failure. And so you see here, cocaine is a like reuptake blocks the reuptake of catecholamines and dopamine within the synaptic cleft, result in accumulation of overstimulation of postsynaptic nerves and antagonizes sodium channels, resulting in impaired nerve conduction. It prolongs depolarization and decrease amplitude. So it's being used as a local anesthetic as well in the not only decongestant, also it's a local anesthetic. So it has both immunosuppressive and pro-inflammatory actions and potent prothrombotic agent. So it will also causing thrombosis. So palpitation, epistaxis, sweating, headache, anxiety, tremors, muscle spasm, hyperventilation. So hyperthermia, hypertension, tachycardia, mydriasis, seizures, stupor, and then you can say everything. For all bad symptoms will be there whenever there is a stimulation like this. So
I have a question there.
yes,
What does it say? Hi.
yes, Bilal.
Hi. Yeah. So if someone comes with the history of cocaine abuse, so what is your idea that when it's safe to anesthetize the patient and when not? Of course, if it's emergency, limb or life situation, we take risk. But what is the time frame that if you see a patient who is on regular cocaine? So two questions. How are you gonna make sure that still he has cocaine metabolites or active cocaine drug in the body? Second question, when it's safe to give anesthesia in terms of time frame?
so I think 24 to 48 hours since last cocaine has been used, though we have to do the levels, we have to do it clinically, and we have to do examine the patient, and of course we have to do the ECG, the cardiac enzymes level, because it can lead to raised troponin, raised increased suspicion of ischemic heart disease. So we have to evaluate regarding history examination and
Bilal, I
then
think the answer to this question will be that itself cocaine will be not be very prolonged action. Sorry, prolonged presence, but the effect of the cocaine will remain for some time. Am I right? Is it like this?
Yeah. So we have to run a urine testing for all opioids and other drugs and cocaine as well. One point he already told, and second is that at least it should be beyond within 24 hours. Because if it's within 24 hours, there is very high risk chance of spontaneous pulmonary hemorrhage, spontaneous ICB, MI with ST elevation. So even any they can bleed anywhere. So within 24 hours, if somebody took cocaine, there is no point to anesthetize that patient. Whatever, even it's a regional with sedation or general anesthesia. So all here we have a lot of population who are cocaine addicts. So people even tell them straightforward that your life is at risk, so you have to be truthful to us, because still people lie, people don't give proper history because they know that there is insurance system and it's very hard to get a scheduled surgery. So they are quite smart, and if they have any idea that we are trying to investigate the last cocaine intake and it's gonna affect the decision that we are going to proceed or not, so they keep manipulating their statement. So we run a urine analysis stat in holding area, and it should be beyond 24 hours. Otherwise, it's not safe. Someone who is having cocaine intoxication. Second question is that what are three drug poisoning where charcoal doesn't work or it is not indicated to give activated charcoal?
sir, in kerosene, I think it did not work. And
Kerosene. You can Google. I think kerosene is not there. I think one is lithium, one is iron, and one is aspirin or what. I'm not sure. If you can check, because it sometime examiner ask it, and even sometime they test this concept in
So
multiple choice
charcoal is
question.
contraindicated in cyanide, fluoride, hydrocarbons, ethanol, methanol, all these things.
I
Alcohol,
also
one is alcohol, right?
well
One is lithium.
lithium, iron,
Yes, one is alcohol, one is lithium, and one is iron, I guess, right? The
iron,
most
and
common
Acids,
one.
corrosives
alkalis,
and
acid
corrosives.
alkalis, corrosives, and mineral acids.
No, corrosives is for that you cannot put a NGT, right? Corrosive is that there is a risk of perforation. I guess that is a
Perforation.
different concept. The corrosives or alkalis are that you cannot decompress their stomach. You cannot aspirate anything back because there is a risk of, you know, digestive tract perf. But I think activated charcoal doesn't work in most common. These three are like alcohol, lithium, and iron. But you need to check on it because I'm not doing ICU since long time.
We all of us are deficient in ICU. So,
And
so it's
second question is that they ask, it's a very favorite question, that what is the toxic dose of paracetamol in a healthy patient, and what is the toxic dose of paracetamol in liver compromised patient, like somebody is HIV, IV drug abuser, Hep C positive, Hep B positive, chronic, malnourished, okay, extensively losing weight. So if it's a normal healthy person, the dose is 150 milligrams per kilo. But if it's a compromised patient, the toxic dose is 75 milligram per kilo.
So
which is usually one tablet comes in 500 milligram strength. And this is, I guess, a rule of pharmacy that in developed countries, they don't sell a strip containing more than 12 tablet over the counter unless someone prescribe it. So that's another way to save it, to save these poisoning cases. Okay.
okay. Thank you, Bilal.
Okay, Zishan, you can mute me. I don't have access to phone actually. Actually,
No problem. Actually, it's very hard to mute you. I never want to mute you. Just a second, please. Okay, so let's see what are some other points, because basic things are the same. So if you have they have asked you this question, then I'm again saying that your mechanism will be, history will be important thing. At the same time, you will try to see the note down the features, and what are the preliminary diagnosis or preliminary indication for something. You will go towards that thing, and the rest of the thing will be supportive management, airway, breathing, circulation. If the conscious level is treated, you will maintain the airway. At the same time, you will try to reverse it. If the proper history is there, fine. Otherwise, you will send the samples and you will try to give the antidotes as per the data or as per the sign symptoms you are getting. Okay, so I think that's what will be there. Gastric lavage. So, the thing which was written for this activated charcoal, not only it was Bilal, it was both things were written. I just also Googled. So it was written that the activated charcoal can create this because for activated charcoal, you need to either the patient is conscious, is drinking by himself, or you need to do it with the NGT. So in corrosives, you cannot pass NGT because it can cause rupture and anything. And maybe endoscopic, with the help of endoscopic, maybe you can try. And it is also saying it does not bind these alcohols and hydrocarbons well. So this is also thing which is written. Okay. So activated charcoal here is also written. Some words you can read about it. Uh, the charcoal to toxin of 10 ratio 1 with a usual dose of 20 to 50 gram or 1 gram per kg in a child. So because this question they can ask you, and because this is a common thing you should be knowing. Okay. So induce emesis. At that time I was not able to recall this word. So ipecac, this is inducing the emesis. Okay. And whole bowel irrigation. This is also something. And another thing which is there, that if any condition in which there is intestinal obstruction, so in that case, you have to give as this activated charcoal with carefully. So okay. So alkaline diuresis for weak acids, and sodium bicarb, hemodialysis. So we saw a chart which medications are removed through dialysis. Uh, we have read about it, I think.
and there is one another point. Of course, if you are going to go for critical intubation patient due to
Bill,
previous teeth was that head up positioning, like, head side elevation to mitigate the risk of aspiration. But now the recent guidelines say that if we compare the head side elevation 30 degree to reverse Trendelenburg position, the more safer approach is to do Trendelenburg positioning, because head elevation to 30-degree, put a little bit increase in intra-abdominal pressure, which can be, triggering the gastric content regurgitation. So in these patients or any patient where we are considering to go for rapid control of airway with RSI, so that is out now. So trend RT, reverse Trendelenburg position, is more effective and more helpful.
Reverse Trendelenburg position mean head up position, Bilal. Can you repeat, Bilal?
Whole table is tilted, right, upside down. Okay, but
Yes.
if we do head up position, it breaks the table in the middle, right? It's
Yeah.
only
Okay.
elevates head side, right? So by doing this, it increases intra-abdominal pressure, which can help for gastric contents to regurgitate.
Like you
So
are saying
reverse
that
Trendalen,
if you are making a head up position, it will become like this. So no, this is not good. This one is good. Okay. So this is
yeah.
reverse.
No, I'm not saying the guidelines are saying it.
No, no, that
I'm not
it
saying.
makes
Don't.
sense. It makes sense. It makes sense.
Yeah. Yeah. Yes.
It makes sense. Okay. So another topic which was asked, I'm not sure recently it's been asked or not. So in one of our exam, and one of colleagues, they face this topic. So snake bite or scorpion bite. So generally, what happened with snake bite? Actually, there is a um, local effects, and when it is absorbed, it has cardiotoxic effect, neurological effect. It can be, so it may be myotoxic or neurotoxic. So this is the and sort of anaphylactic reaction can also occur. Thrombosis can also occur. So because this is a very terrible topic, if someone gets in the exam, he is very unlucky. Have you guys read about it? So
Yes, sir, I
what?
have read little bit about it, sir. So
Okay,
basically,
so
there are three kinds of toxin: neurotoxin, vasculotoxic, and myotoxins. Sir, different kind of snake genre. It causes different kind of toxins, release different kind of toxins and on the basis of these toxin, whichever toxin is the symptom, sign and symptoms, and management is different, sir. Regarding the main difference is the toxin that the snake bite has.
okay, so the what will be the general like pain relief will be one of them. Supportive treatment include this reassurance, immobilization of effective limb. You put a tourniquet. Tourniquet is a constricting band to delay absorption, and venom spread has been advocated during transit to hospital for bites to a limb. A firm but not tight ligature may be applied just above the bite. The tension is correct if one finger can pass between the limb and the bandage. This will also impede lymphatic drainage, but not arterial or deep venous flow. So this is one thing. And then in CN and mechanical suction of the bite intended to open the puncture wound, so that suction can be more effective. Okay, so this is another thing. Uh, Extractor, application of cooling measures such as ice pack or cryotherapy at the site of bite were initially advocated but have not been proven to be effective. This practice is not recommended. Anti-tetanus toxide should also be given following snake bite. There is controversy behind use of drugs. Uh, Suggested NSAID may be beneficial to relieve local pain but may precipitate bleeding because they have this bleeding tendency. So what else we will be doing? Airway, breathing, circulation, and uh, ultimately the anti-venom therapy. Okay. So anti-snake venom are prepared by immunizing horse with venom for poisonous snakes. So this is anti-venom. So whenever there is muscle involvement is there, you can say about these enzymes like CPK, okay, and coagulation pathway, hyperkalemia, if ABGs. So, okay. Anything else about it? So antivenom should be given within 4 to 6 hours of the bite, and the dosage required varies with the degree of innovation. Okay. So fasciotomies should be undertaken in patients with compartment syndrome. Okay, and coagulopathy should be corrected with FFPs and platelets. Blood transfusion should be given to replace blood loss from hemolysis and bleeding. Ventilatory support and hemodialysis may be necessary for pulmonary and renal complication. Actually, if you understand that if you say anything like rhabdomyolysis or any muscle problem, so either you will do the compartment syndrome treatment, or you will do the rhabdomyolysis and following AKI. So prevention or anything hyperkalemia or arrhythmias should automatically be there. Okay. Our friend immunoglobulin therapy will also come into help. So, so yes, scorpion. I have the honors to be bitten by a scorpion, and that was the worst pain of my life. But maybe it was I don't know what sort of scorpion it was, but I can tell you that the worst pain of my life. So, but another thing is that usually they are not fatal usually, but it is very painful. So some of them you see in the venom of this big scorpion contain 5 distinct neurotoxins that stimulate depolarization of neuromuscular junction, autonomic nervous system by acetylcholine, norepinephrine, and epinephrine. Cardiotoxic effects have maybe some types. Okay, so uh, it was one of the most difficult topic to discuss because we usually don't we are not dealing frequently because actually this is an emergency medicine topic. Am I right?
Yes.
So, anyways, thank you very much. I will stop here. And, I will suggest Zishan and Safiullah and Abdurrahman is not coming these days. Any topic which you want to discuss, just let me know. So, I will just try to have some because a lot of topics we have already discussed. Uh, I will be trying to get some help with reference to basic sciences. So we will try to quickly have a look on these uh, equipment and physics because one of the topic, atypical topic can be for like MRI, ultrasound, pulse oximeter, end-tidal CO2, cardiac output monitor, scavenging, humidity, vaporizer, oxygen safety system, oxygen supply system, okay, then agent analyzer. So actually, inshallah, we will try to have a session on this uh, one topic with ICU. Do you know this format? This will help you in identifying my suggestion will be that open these links and have a look any topic which you don't know at all because there are so many things which are common. Okay. Another thing I would suggest you that you make a 30 seconds to 1 minute answer of all the diseases. What is asthma? What is COPD? What is thalassemia? What is sickle cell disease? What is diabetes mellitus? What is hypertension? What is heart failure? Like try to make the words in which you compact, bring all the features and all the things related to anesthesia. Okay. So because this will help you in the exam. Believe me, it will help you a lot. Then if you are talking about this equipment physics, the first question will be related to all these things. What is the mechanism of action, or what is the working principle? So you should be prepared for this. Then the next question will be, what are use utilities, what are troubleshooting, what are limitations? So what are different interpretations? So if anything coming, you should be knowing. So like similarly, like vaporizer working principle, different types of vaporizers, how they work. So same is true for almost everything. So prepare the answer, rather than if you will open the topic from any book and you try to read each and every line, unfortunately, maybe you will have dizziness. But if you just prepare in that way, if you don't know, if you don't like to read too much detail about that topic, at least extract these few answers, so that if they asked in the exam, you are able to answer. So this is something I will highly. Similarly, with reference to pharmacology, make groups of medications, okay, and just try to have few words. What is the mechanism of action? What is effect on various system, and what is relationship with the anesthesia? Even if you know these things with all the medication groups, it will help you in the exam, because any medication suddenly they ask, and you know how to answer, because this can be asked in least likely in table viva, most probably about pharmacology. Usually they can ask you in the long case. In table viva there is no time. In table viva there is no time for small minute details. If you are able to answer in a broader basic concept, they will never fail you. Okay, so we have tried to cover almost everything. That's which whenever whatever thing is missing, I will try to fill in gap.
And
So
one thing more that
yes, Bilal.
which the part where we are deficient in ICU in every topic, we always forget that family update, family meeting, what you are doing, okay? Uh, Frequent review of anesthesia related events, how patient condition is improving or worsening, patient is going on more inotropes or coming off pressors, and how so ICU is basically the people who are sitting on the front desk in ICU as a physician. They are just being treated as a postman. They're just making a lot of letters, throwing those letters to ID people, to some GI people, to cardiologist, to neurologist. So it's not a very complicated, but if you stick to the basics, like you have to review every system of the patient, and you have to make sure that which consult you need for this patient, which investigation you need for this patient, okay, what your ventilator is telling you if that patient is mechanically ventilated, especially the amount of secretions, color of secretions, requirement of FiO2s, worsening imaging, like what is uh, current finding on X-rays, those patients are developing VAP or not, or some other patches. And you have to tell examiner that we will make sure that we keep updated the families, and every day there should be discussion about that patient among different uh, disciplines, that what is the plan, what are the goals. And few patients are just holding the ICU bed, so we never been taught that how to decide about futility of treatment, or hospice, or withdrawal of care, how to review the DNR status, what are the procedure where we have to reverse the DNR codes, right? So these are few important things. I know that no one teaches about it, but I think it's important not only for passing an exam, even to be a better clinician.
Yes, you see, this is all a very, because this will be a question which which can surprise you. Just like palliative care. One of the exam we were asked about palliative care, and I was not able to. It was asked to me, and I had no idea whatsoever. Similarly, in the same exam, I was asked about ICU admission, ICU design, and I had no idea uh, at that time. So suddenly these things can then these can occur. Similarly, this topic, as Bilal mentioned, this because every time they try to create something new. So this is one of the, so this like a folder can help you. Okay, so just try to open, and no, you don't need to have two big answers. Even few small points can help you. Okay. So thank you very much, Bilal. You were, if
Second
you,
thing that I would like to mention, that try to, solve your questions at your level. Issue is that we are not very well trained to explore things, to Google stuff, to use AI, like artificial intelligence, to get answers about the question. Today, this morning, I was waking up and someone was from Bangladesh. He was trying to reach to me via WhatsApp. He took my number from this group and he was asking me very basic question answer regarding some raised ICP treatment. So we are not here to spoon feed like very basic knowledge. We are here to give you some expert opinion if we know about that, but every human has a limited functional brain capacity. So might be possible Dr. Zishan or even professor don't know and every part of literature at a certain period of time. So probably try to solve this stuff at your level. Though we are accessible, you guys can reach out to us anytime, but you have to stratify that where you really need to call or to contact. I'm not refusing to help anyone, but sometimes people start shooting questions on social media, on your social media like WhatsApp or wherever, with very basic and easily solvable issues.
okay, thank you very much. I was just thinking that we will just try to have few Viva scenarios, just brainstorming, which will be journalized. So I will try to have these discussions as well. I'm not touching the some of the topic which were done by Dr. Fazal in detail, like respiratory system, or some of the topics which I know that he has taught in very detail. So inshallah, we will try to cover as much as possible. So you all are welcome anytime. If any help we can do. Thank you very much, Bilal, and thank you all of you.
Okay, sir.
So, Javeria Atazaz, you want to share something? Uh, your request is here. I don't know what is it. Okay. So, anyways, thank you very much. So, inshallah, we'll meet tomorrow. Bye bye.